So here we are on the couch with Vince Berry. Vince is the CEO of Pegasus. Vince, welcome.
Thanks, Mark.
Vince, like to chat to you about telehealth.
Sure.
And the concept of telehealth. What are Pegasus doing at the moment as far as telehealth is concerned? Any plans or?
So we've got some facilities available, Mark, primarily for our education sessions. So I think we've got it the wrong way around. What we've done is we know we need to project out our education program and across a wider network, because we now have Kaikoura and Methven as part of our Canterbury network. And but we'll put technology in without thinking about the change management process. Mm-hmm. So aspirations are to be far more connected by being more remotely available, but not too sure whether we've gone through the change management process.
Yeah. So education, to me, it seems to be like the low-hanging fruit.
Yep.
And it sounds as though you're thinking along the same lines?
Yeah, absolutely. But for some of those remote practices, the question's got to be around how can you provide treatment, support and backup. I think education can probably be the more acceptable entry point. For lots of practices and practitioners. So, but there will be these pioneers. There will be some of those guys at the front end wanting to have a crack. To me, the success of it's going to be how we get most of the people using it at a minimum level.
We always talk about low-hanging fruit in technology, as far as, well, what are the easiest places to connect? How can we connect this place with that and who's willing to talk? Because a lot of people think of the one end of it. Yeah. And they put the technology in, but then they've got no idea who they're going to connect to.
Yeah, and I think that's the process, and we've had discussions before, and there's a couple of things around the whole telehealth stuff. One's the definition of what you mean, because I think for some people it frightens people, and as I said a few minutes ago, what I don't think we've done well is the whole change management process. We believe that technology is a great thing, because we're told each and every day that there's more and more technology coming in, but we've got a whole lot of operators who at a conscious or a cognitive level, an intellectual level understand it, but at a heart level they're worried about what it might mean for their work and what they're going to do. So I've got a view that we've got a whole lot of work to do at the front end of it. The ideal opportunity for us around education is our education is driven off a really interactive education program, so it's not didactic. And if we can get it right, then the technology will be a very good enabler. And I suspect what we've done is we've gone, the technology's great, now we'll try and enable things to happen rather than the other way around.
So what are some of the problems you think that maybe solved? After hours would be an issue that could be solved by video?
There's no doubt the confidence. So the confidence for clinicians, practice teams, beyond medical staff. So as you'll well understand, the ability to get medical staff into the front line after hours remotely is really difficult. So we have now clinical nurse specialists, or have got the odd nurse practitioner around the country, and so giving them confidence and connecting directly back up. So for example, in the Canterbury experience, we've got the 24-hour surgery. So it's well staffed, well medically staffed with very very specialised staff, but we've got people in remote areas, and so the ability to have the confidence by using that technology after hours for clinical purposes, and the education. So all the education, most of it now with general practice teams, is run post 7 o'clock at night.
Is the after hours in Christchurch wired for video?
No. Okay. And that's what we want to do.
Yeah, okay.
So part of our program now is we've brought into Pegasus Health's a part owner now in Home Care Medical, which is pretty much the after hours nurse triage line, which is a telephony approach, and
which is also telehealth.
Yeah, that's right, and that's the whole issue, isn't it? It's about trying to get the right description, but we need to extend that now. Certainly for the remote areas, that's the one core. And so how do you extend that technology safely? And I think you mentioned a minute ago, well, what could be some of the issues that need to be addressed? I think it's operator issue, getting people confident with the use of the technology, and seeing that as just a natural extension of either a consultation or an education interaction.
And people are scared of technology, and you're right, it's getting them to break. They can't break anything.
Yeah, and it's that confidence, isn't it? I mean, we've all got smartphones now, so there actually is a technology stuff there, and it's trying to treat this technology like that.
Now, just thinking about from the other side, are you getting much demand or patients? Because you're right, cell phones are the way to go. So are patients kind of pushing up, saying?
I'm not sure. I think there'll be pockets of that. and apps are available for people to start using. So we're seeing symptom checker apps and these sorts of things start to appear in the environment. When I talk about the change management process, it's as much a change management process with our communities, socialising them to actually what is available, because I've got a view that they'll be the biggest drivers of change, because they'll demand that's the way I want services provided to me. And so at a sort of at a strategy level, we've got all the agreements in place. You know, we talk about, in Canterbury, we talk about three principles for the design of the system. One is self-management, give people the tools to self-manage. The second is continuous care around the healthcare home. And the third one is sort of making available specialist resources, so hospitals are accessible and responsive, and people get care in the right place. So you start stitching those together, and we need to have a conversation with our communities around actually what rights they've got around this stuff, and I think they'll drive a whole lot of the change. They'll be demanding from their general practice teams and their clinical teams. I don't need to go into Christchurch. Why do I need to go into Christchurch for that procedure? I know that I can have this here, or actually I don't need to come and see you, doc. I can have this relationship with you in other ways. We are starting to see that breakthrough with a lot of email contact and with our general practice teams now. A lot of GPs will do that, and they'll say to people, email me before you come in, let me know what the things are, and actually I might be able to you might not need to have to see me. And so you take that to its natural extension.
Have you got a portal? A patient portal?
No, so that's the big, and again, a bit like TeleHealth.
Yes.
What's the description of a patient portal?
Yes.
Is it everything from me making an appointment or ordering ordering a prescription, or actually me seeing my notes? And so we're working with Orion Health now and the DHB we're doing a proof of concept around portal, because there are some off-the-shelf products that are around, and I suspect they'll be limited. So we have started that conversation. So the three of us are working quite closely with that, based on the platform of the eShare Care Record View that we developed with the DHB and Orion post-earthquake.
And that's working well, I understand?
Yeah, look, from a user take-up, absolutely. I mean, huge amounts of access. Still, I've got a personal view, it's still quite limited in the information that is available, but at least it's starting to show people around the system now that their information, their relevant information is available at point of care. We've got still some anxieties from some of the professional groups around how much information you make available. It's very much like the change management process we had in mental health when we put in the SAP program. The breakthrough for patients and that interaction is going to be the portal, and I think we've got to move with caution but with pace. I know it sounds a bit oxymoronic, but the risk will be that we believe patient portals are a good idea, but actually have we gone to our communities and said, what's important to you? And that's a lot of the stuff that I'm beginning to think about with technology, that we develop all these really fancy apps and things that seem to work really well, but actually are our communities going to use them? So I come back to that discussion around socialising what's available and what rights you've got. But
I've just come back recently from the States at a telehealth conference, and the thing that blew me away, two things, is that the number of video GP consults that are starting to happen. Which and people just going online, booking someone with a rash or something relatively simple, didn't require a relationship. They're getting that online now, and there's thousands of places you can get that from.
Yeah, well, I think we've got to standardise that. So, I mean, I was introduced the other day to an app on the phone that you can whack over a skin mole, and it sort of starts telling you, oh, you better go and see your GP. This one looks a bit ugly, and so again, socialising the clinical community to so can we standardise some of that stuff? So you know that if I'm sending you a picture about something, then you know what the standard of it is. We've had a bit of a pushback from some of our primarily general practice teams who are saying, or GPs who are saying, look, my day's going to be crazy if these people get access to all the information. They're going to be at me all the time. That's not what the evidence suggests. The stuff that I read off from the States is that you give me access and I'll actually use that responsibly.
Thinking of patients, one of the things that struck me in the States was the in-home monitoring. And it's been brought about from a cost perspective from health insurers. So what they're saying is that we could spend $15,000 putting a whole lot of kit into patients' homes, All that links to a smartphone as well. So it's reverse burglar alarm. So you have a sensor in the kitchen, and if it doesn't go off between 5 and 7 at night, it gives an alert to someone, and then there's some smart data, some parameters, so that the nurse phoning the next morning or coming in the next morning will get an alert on their phone saying Mabel probably hasn't eaten.
And my anxiety is, and I think we've got a debate with our community, which is, how much do we want to monitor that sort of stuff? How much do we need to know? The fact that Yvonne didn't get up at between 5 and 7 might be fine. She might have just felt buggered that morning or that night or gone to bed early or got up late, and then all of a sudden the daughter-in-law gets the message on the phone, says, shit, I better get around there because Yvonne hasn't gone through that area. So I think we're going to have a debate about that and a discussion, and what is the best use of that technology. And maybe it's a generational thing, mate. Maybe for us we might want that because that'll be right, and we'll have our houses wired anyway. But I'm just a wee bit worried that we're applying and imposing the technology when possibly it's not wanted.
And I also think of the graph, but the difference between GDP and the cost of healthcare in the next few years, and unless we do something, and maybe technology is the enabler to try and change that, but something radically is going to have to happen in the next little while, because you'd be seeing it with primary care, with the bubble starting to come. And I think we're doing things smarter nowadays.
No, there's no doubt, and there's no doubt the system's shifting. For me, though, I think, there's that study that came out of Stanford in the 80s. The guy his hypothesis was if you compress morbidity, compress infirmity, then you actually get a better bang for your buck. So basically, simply put, if you keep us well for as long as possible and die for a shorter period of time, it's going to be the right thing to do. And it's not the sort of debate you want to take to a grey power convention, but it's a fascinating concept when you think about the intervention process. I know talking earlier, we were talking around the amount of money that goes into the last 7 days or 3 months of care. So if you're looking at the best bang for the buck, you've got to get to the front end of it, which is how do we manage our communities and get them to self-manage and think about healthy lifestyles and those sorts of things, and then how do we manage life in a dignified way, because we know we're all going to die
Quickly.
Yeah, well, it's interesting, isn't it? So if you're going to get diabetes, can we compress it enough that you don't get it till you're 65 rather than at 55? Because that's where the spend goes. You're absolutely right. Technology is going to have a huge part in the efficiency and the effectiveness of the system, because that's the way we will move, and our expectation will be that. And we see it with the banking industry is a good example of that, isn't it? But they've also shifted back a little bit around the personal care.
That's exactly right. Yes.
And so they've gone through a process of digitising everything and making it so remote that it's just have a relationship with me online or in that sort of sense, or a telephone, through to, now we've got that sorted, we need to come back because actually I do need a relationship with you.
Yes.
Having a private bank is sort of okay. And so health will probably have some of that that part of that journey too, I think. I'm a great fan of, let's not sort of lean the soul out of the health system, because health's, as we can remove a whole lot of activity by me taking responsibility by having technology available. Or people getting access to better services because technology is available. But the personal relationship is going to be a core of that interaction, I think, that we have to maintain. So, it's just an interesting debate, Mark. I haven't formed a view. I'm not a stoically just keep bloody smartphones out of this, or let's just go hell for leather. I just think it's something we need to be mindful of and keep talking about.
And I think you're right. It'll shake down in the end, because you try something that's new, and then it either works or it doesn't. But it's universal acceptance, and it's not necessarily the app or whatever. But it's how do I want to be treated as a patient? And really that comes down to at the end of the day. And that whole personal responsibility. How do I know that I'm getting better? How do I know that I'm getting worse? The fact that I go for a blood test and then, phone the doctor a week later, am I well or am I not? As opposed to that whole positive feedback that you're getting instantly from stuff.
Yeah, and the whole society is getting more instant, isn't it? You would like to know once, because what I think a lot of us forget in the system, designing it and delivering services, is actually most people when they come along, they don't really want to be there to have a test. They're worried, they're anxious, and so the more you can reduce that anxiety, or the quicker you can, It's really important. But the IHI guys talk about, health improvement guys talk a lot about let's fundamentally move the healthcare system from what's the matter to you healthcare system to what matters to you.
Yes.
And some of that's putting the power of treatment and care and stuff back in my hands as a health user, and we need to be mindful of that with the technology surge that's around, because there's some really smart stuff out there.
We've covered a lot today, Vince. Thank you very much for your time.
Thanks, Mark. It's an absolute pleasure, and thanks for the invitation.
That's all right. Cheers. So there we are, finished on the couch with Vince Barry from Pegasus, and we'll be back soon.
Great. Thanks, mate.